Adiba Kamaruzaman, the Dean, Faculty of Medicine, Universiti Malaya, who will chair this afternoon's lecture, and Professor Dr. Chirk, Department of Primary Care Medicine, Faculty of Medicine, University of Malaya. Can we please stand for the national anthem and UN song?
Universiti Malaya, kebanggaan kita semua. Bertambah para ilmuwan di pelbagai lapangan. Kami bertekad di hati mencapai cita murni. Tradisi kecemerlangan menepati wawasan. Di sini kami sedia berbakti, terus berinovasi. Kami harapan generasi muda, teras nusa dan bangsa. Varsity kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya. Di sini kami sedia berbakti, terus berinovasi. Kami harapan generasi muda, teras nusa dan bangsa. Varsity kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya.
Good afternoon, Professor Dr. Adiba Kamaruzaman, Dean of Faculty of Medicine, University of Malaya, Professor Dr. Tengku Kamaruzaman bin Tengku Zainul Abidin, Director, Universiti Malaya Medical Centre, His Excellencies, Tan Sris, Datoks, respected professors, distinguished guests, Professor Dr. Chirk, Management of the Faculty of Medicine, University of Malaya, ladies and gentlemen, welcome to the inaugural lecture by Professor Dr. Chirk entitled Putting Patients Back to the Heart of Care. Without further delay, I would like to invite Professor Dr. Adiba Kamaruzaman to chair the lecture and to introduce Professor Dr. Chirk.
Thank you, Dr. Adina. Good afternoon, everyone, and thank you for coming to the first of the series of inaugural lectures for this year, 2016. And I can't think of anyone better to start the ball rolling for this year than Chirk. I guess in reading your CV, perhaps Professor Chirk could be best described as the one who almost got away. And what I mean by that is, we have this rivalry with our twin or our cousin or our stepbrother, whatever you want to call NUS, because Chirk did his first degree at NUS and subsequently also stayed on to do masters in family medicine, and fortunately for Universiti Malaya chose to come back to Malaysia and to Universiti Malaya. Not many of our graduates who go down south choose to do that, and certainly I think the faculty and UM are so much richer and better for it, because Chirk Jenn has been one of the shining stars in the faculty, combining his clinical prowess with his academic achievements. I think Chirk Jenn has been one of the leading academic staff in a small but very productive department of family medicine. They've probably got one of the highest ratios of clinicians to PhD compared to many of the other clinical academic departments. So it certainly is a tribute to the department, but also to Chirk Jenn, who's been leading many of the research projects and programs in Department of Primary Care. As an internist, as an internal medicine, I always admire people who choose to do primary care, because really you are the consummate doctor. You have to know everything from pediatrics all the way to terminal care, and I, for one, who's never spent a day doing general practice, really admire those who do primary care, and Chirk Jenn and colleagues are really leading the university as well as the primary care fraternity as a whole in trying to build up the specialty of primary care. And I think at last count, we've put the task at you having to produce something like 20,000 primary care physicians for the country. No small task, but with his background and his contribution actively to the Academy of Family Physicians of Malaysia, I'm sure that Chirk Jenn and colleagues eventually will be able to achieve these 20,000 primary care physicians for the country. But I think where Chirk Jenn has really made his mark is in driving research in primary care. And he has certainly established close collaboration with researchers from the UK, Australia, and many parts of the world. And he was also tasked recently and has done an admirable job of putting hopefully blended learning, open source learning for clinical research, which we hope to, we're trying it at the moment, but we hope to expand to the rest of the faculty and to those who are doing other clinical master's program for the requirement to complete a project. So he's been a busy man, and on top of that, he's now taken on the big task of being the deputy chair of the ethics committee. So I'm glad to see the title of your talk, Putting Patients Back at the Heart of Care. I think it's very easy to lose sight of what we do and who we are, and I look forward to hearing how Prof. Ng's research into patient decision making will lead us into better patient care. So over to you.
Thank you very much, Prof. Adiba, for the kind introductions. Distinguished guests, friends, colleagues, family members, it's an honor for me to be here speaking to all of you today. And I know many of you are having busy schedules and clinics, and you have to cancel them to come to this lecture. I was just thinking, considering the man hours that we have here, the cost must be tremendous. Right. Before I start, I'd like to thank many people here, or not here, who have made this possible for me. First of all, I'd like to thank the organizing committee, the ICR, the Dean's Office, the departments, particularly Puan Nor and Wen Ting, for putting this all together. I'd like to thank my teachers, both in all my years of schooling, in NUS, as well as in UM, particularly Prof. Chia, who is not here today. I also like to thank my colleagues from Department of Primary Care and from the other departments who have helped me along the way, and as well as, of course, my students who have kept me on my toes and keep going. And last but not least, my patients who have inspired me to put up this title today, Putting Patients Back at the Heart of Care. Okay, let me start. As a primary care physician, I will attend my clinics quite regularly, but these days a bit less now, about once a week. Used to be once every day. So, and I tend to hurry across to my room, consultation room. Actually, most of the time, don't looking at my patients. I just walk into my consultation room and get my patient's consultation started. Usually, there's a long list, and I have to rush them through. So sometimes I wonder what's happening to the patients outside my consultation room. Like this particular man, what is going through his mind? What has he thought about before he even come to see me in this clinic? Is he going to think that, am I going to see my regular doctors? He's not going to be around because he's attending meetings. I'm going to get my test results today. What's the results going to be? Okay. The doctor said that I'm supposed to start insulin this time if my blood sugar level is not good. So, but I don't want to because I have a lot of concerns. Or maybe I have lots of work waiting for me in my office and I just want to get through this as fast as I can. So many things goes through their mind, but how much do we know about what's going on in the mind of this particular patient? But this patient's not too bad. He's alone. I don't think he has to wait for too long to get his turn. More likely is this. Okay, this is, I think, A&E department. So long queues, and they have to wait out, well, hopefully less now, right, under the guidance of Prof. Tunku Kamaro. And the waiting time is cutting shorter, but still they have to wait a long time. But when they get in, the doctors probably stand about 10 minutes, 15 minutes at most, to see them. So are we really achieving what we set out to do, is to help patients with their illness? This is if those of you have been to RUCA, Department of Primary Care Medicine, this is a typical consultation room. And there's my ex-colleague, Dr. Thin, who is from Myanmar. And this is a nice Chinese lady. Let's call her Madam Tan. Okay. Obviously, Dr. Thin doesn't know how to speak Mandarin. Neither does Madam Tan knows how to speak English. So most of the time, they will converse in Malay because Dr. Tin knows Malay. So, well, Madam Tan has lots of problems. She has diabetes on insulin. She has hypertension. She has dyslipidemia. She has osteoarthritis of the knee. She's slightly pale. She's a vegetarian, so a bit anemic. And of course, the husband just passed away. She's just deceased, and she's coping with grieving. Lots of these problems that are typical patients that we see in primary care, really. So Dr. Tin has to deal with all these things. So the patient typically spends 15 minutes with us, at most 20 minutes per consultation. So each year they see us for four times a year. So that is about an hour a year. What happened to them the rest of the year? 364 days and 23 hours. How much do we know their life beyond the consultation? And every day, Madam Tan has to grapple with, and that's just the health, just the diabetes, about her diet, about monitoring her sugar, about remembering to take her tablets, her medications, and injections at night, once a day. So, but this is just part of her life. This is just the health part of her life. How about the rest of her life, the social part of her life? We don't know. Her children, her grandchildren, she has to look after, the grieving, now losing her husband. So how much do we know about our patient really? And when we try to manage our patients, all this comes into play because all this affects her life, including her health. This is a paper that Wen-Tin did for her master's, and Dr. Sharini and myself co-authored. Why do some people with type 2 diabetes who are already on insulin still have poor glycemic control? It's an exploratory qualitative study. And these are my attempt to try to show you some of the voices of patients, their needs, what's happening in their life at home. This is an ex-lorry driver. He was a lorry driver until he had to start on insulin, and he kept having hypos, and then he has to stop driving. Every time, he spoke in Cantonese actually, every time the doctor asked me to eat bread, can you eat bread every day? For sure you will hate it. They will ask you to eat vegetables every day. Cannot like that, you know. As much as doctors, part of the things that we do is to advise patients about our diets. But to the patients, you know, diet is just part of their life and they enjoy eating. So you're asking them to eat bread, you know, go on cereals, milk and all that. It just doesn't work. Do we know what they're doing at home? This 40-year-old officer, government officer, I don't quite like insulin actually. I'm very afraid of needles and the pain that follows. In a week, I would say at least 3 times I would skip the insulin injections. These are interviews from patients, and there's no wonder the sugar is high. But we can't solve their hyperglycemia, the high sugar, unless we deal with the root of the problem, that he's afraid of the needles and it's painful. This is another paper that we published with Wen Mei and Prof. Chua, barriers and facilitators to self-monitoring of blood sugar in people with type 2 diabetes. And these are the voices of this 61-year-old retired teacher living with diabetes for 20 years. If the blood sugar reading is a bit, let's say 1 or 2 units higher, I get frustrated. Why is the blood sugar not coming down? That's frustration. I pray 100 times. I pray that it must not be more than that before they did the blood sugar monitoring. Then I prick and see, oh, it is more than what's expected. Before diabetes kills me, the mental torture will kill me. And that's why I just couldn't be bothered to check my blood sugar at all. So this is exactly what's happening in the real world. Despite the fact that we say, you must monitor your sugar, it's very important, then you can gauge, then you can adjust your insulin, blah, blah, blah. But that's exactly what's happening in their mind. Unless and until we address that, the high blood sugar level will not be solved. And let's go back to this lady again, and poor Dr. Tin has to deal with all these things. Her sugar is high, that's because she's not monitoring, she's skipping her injections, 3 times a day, and she just cannot control her food because she just enjoys food. Eating bread, vegetables, no go. So how is Dr. Tin going to help her? Should we? Because for us as medical doctors, we are trained to use evidence-based to try to help this person. Try to use the best available evidence based on scientific research. And scientific research said that diet is important, medication is important, insulin is the way to go. But this patient is telling you that that's not the most important thing to her. I started off as a junior house officer in Singapore General Hospital, attended my first evidence-based medicine workshop. And I was really happy because finally I see the light, because I feel that that's probably the best way I can, the method I can use to try to manage my patients, because I'm just looking at the scientific evidence. For those of you who are not familiar with evidence-based medicine, it basically means that you try to integrate whatever scientific research together, considering your experience, your familiarity with the patients, and then taking into consideration patients' values, what is important to them, and then practice as such. But most of the time, previously, people just focus on the scientific evidence without actually looking into the patient values. So when I was happy seeing that, because it's black and white. There's evidence, I practice it. No evidence, I don't practice it. It's so easy for me, especially for junior doctors. That's why we stick strictly to clinical practice guidelines as if they are the Bible, but little do we know that these guidelines are just guidelines. They are not black or white. There's a lot of gray in between. this is, sorry for the confusing map. And if you think about it, if evidence-based medicine is practiced by the doctors worldwide, and this is embraced as the way we should practice medicine, we should see that those patients who require certain treatment should be receiving it. But just look at this map. I'm using the US data. Hopefully one day Malaysia will have the same kind of data. It's a Dartmouth Atlas project, some of you may be aware. It basically maps out the practices across the whole of United States and try to see whether there's variations in how doctors practice medicine. The darker the redder it is, means that the more mastectomy is being done for women with breast cancer. As you know, mastectomy, for early breast cancer, you can either do mastectomy, which means you remove the whole breast, or you can do lumpectomy, which you just removed a small part of the breast with radiotherapy. So, and you can see that the yellow means that it's not so commonly practiced, whereas red means very commonly practiced. And you can see the variations, even if you look at it, even Chicago, just within Chicago itself, the second one, you could see there are yellow, there's red, and there's dark red. That means even within that small little area, there's variations in how doctors decide whether to do mastectomy or not. It's not because the fact that the women are different, because some are early, some are late, it's not. And also not because patients don't want to do mastectomy. Well, maybe a portion of them, but majority actually leave it to the doctors. And the doctors basically make the decision. This is just mastectomy, which means that the decision is made based on the doctor's discretion. And the doctors know for the fact that if you think about it, if mastectomy and lumpectomy are equally effective in treating cancer, that should be equal. There should not be so much. So, but in this case, there's overwhelmingly a lot of mastectomy in one area versus the other. So I think this is something for us to really think about. And why are we practicing differently if evidence-based medicine should guide us? Ronita, Prof. Liu, myself, Renee, did a study looking at GPs' views and experiences about practicing evidence-based medicine. And these are the conclusions just been accepted for publication. The GPs said that they lacked knowledge and skills, and it really depends on the workplace culture, whether the workplace promote this kind of evidence-based medicine culture or not. It's more in academic institutions like in UMMC, but when you go to private GPs in clinic kesehatan, then the skills and the culture are completely different, and they practice evidence-based medicine less. It tends to depend on more experts' opinion. The shocking thing we found was that EBM perceived as a threat to good clinical practice. When I look at it, I was like, why are they thinking that EBM should be perceived as a threat? And the reason is because, this is from a GP, he feels that evidence-based medicine people tend to focus on research, scientific evidence, and neglecting what the patients think. If we want to be embracing patient-centered care, then we should be thinking about patients, rather than just using the scientific evidence. But actually, in actual definition of evidence medicine, patient values are actually important. It's how we practice it. But this is what people perceive evidence-based medicine as. So, going back to the topic of today is about patient-centered care. When we practice evidence-based medicine, I think we tend to neglect patient values, which is an important part. And if ultimately whatever outcome of the treatment is, patients are the ones who are going to benefit or to suffer or get the harm. So I think when we practice so-called evidence-based medicine, we really have to look at patient values, which are what's important to the patient, what are their preferences, what's important to them. This is a study that's conducted by Dr. Lee Yu Kong, my first PhD student, who is now senior lecturer in our department. He explored what patient values means in the medical decision-making concept. And when we look at patient values, it's not just talking about the treatment-specific values. For example, we talk about diabetes. We're not just talking about avoiding complications important? Is hypos something that I would consider as important to me? But we also have to think about the life goals and life philosophies, because a busy person who is in the in the early stage of their career, their family, money is much more important than health. They will sacrifice health for that. So when we explore patient values, I think it's very important to take into considerations their life goals, what's important at their stage of life. And of course, the last circle is actually personal and social cultural background. Sometimes the religion takes precedence over it. If they suspect that the insulin is not halal, for example, they will not take it. So I think this is a broader context of how we should see patient values, not just about the treatment, but also their life goals and their social and cultural background. This is just an example I showed you, that, for example, starting insulin in type 2 diabetes, we have patient values which are, I'm afraid of the pain, it's expensive, I may faint, because they look at many movies. When you start insulin, you may have hypo, you may faint. Will I get more complications? They think that by starting insulin, they can get kidney failure, for example. Whereas for the doctors sitting on the other side of the table, we're more worried about the blood sugar control. We're worried about, are we achieving our audit targets of HbA1c of less than 6.5%? Because that's what our boss wants us to do. Fewer complications. So you can see a mismatch between the two, the patient values and the doctor's values. And we know that they are not the same. So there's a clash there. So when there's a clash, you can see that the consultation will not go well. And this is the reason why I think before I went for my PhD, I was pretty frustrated, because I was trying here to help you, the patients, to convert to insulin, because I want you to save your limbs, save your eyesight, and prevent you from getting heart attack. But the patient is saying no, no, no. And then 1 year later, they're still not on insulin. So I feel really frustrated. But only when I discovered that actually there's this mismatch that we need to deal with, then I can live with that. So acting in the best of interest of patients may not hold true all the time. I think we need to listen to the patients more. And Institute of Medicine, now it's called the National Academy of Medicine, define patient-centered care as providing care that's respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. And I really like this definition. But this is not saying that we don't need to have competent clinicians. We must, and that's a prerequisite. But that's not enough. We need to take patients' values and needs into our considerations when making clinical decisions with them. And how to operationalize this? I mean, this sounds very soft, very nice, very philosophical. Can you actually convert it into something concrete, something interventional, something that we can actually practice in our daily clinical consultations? No point talking about it if you can't do anything about it. This is a concept of shared decision making, which is introduced by Kathy Charles in McMaster, Canada. And on the one hand is the paternalistic model, which is something that medicine is quite used to. That means the doctors, being the expert, knows what is best and then decide for the patients what is the treatment option. On the other hand is the other extreme, is whereby doctors provide the information, give the patients the information, and the patients just make the decisions without actually needing to ask the doctors what his or her opinions is, which is not usually happens in our context. But shared decision making is in between, whereby patient provides information about their values and preferences, practitioners provide their clinical expertise based on scientific evidence and their clinical experience, and both parties discuss, negotiate, and agree on that decision. This sounds very ideal, and it can be anything in between. It's not three concrete blocks, but somewhere in between also happens. So, but it's with this that interventions are being developed to help patients make informed decisions. So if you look at Madam Tan and Dr. Thin, on one hand is the expert patients who knows about their values, the health beliefs, the health knowledge, and psychosocial background. These days and age, internet is very easily accessible. patients will search for information before they go into the consultation room, perhaps not Madam Tan, but some of the younger generations, they will definitely search before they go in and ask you the questions. Also, on the other hand, of course, are the clinicians with the clinical expertise as well as having the experience of managing patients and knowing this patient's health status throughout, because they're following them up across. So they know this patient's sort of preferences. And they also know the health resources, where to refer the patients, where are the cheaper drugs, and all this. And through this, in the consultations, together with other family members, as well as the nurses, the dietitians, the podiatrists, the pharmacists, that they come to a decisions. As you can see, it's actually very complex. That is a journey that we go through. But truly, do patients want to be involved in decision making? Isn't it easier if doctors make the decision? After all, the doctors should be in the positions to advise the patients. So this is a study conducted by Angela Coulter in 2005, but I think it still holds true until now, that there's wide variations in different countries whether the people actually wanted to make their own decisions or wanted the doctors to share decisions with them. And this is whereby they want to make their own decisions, or the doctors share with them rather than doctors making for them. You see in Switzerland, Germany, UK, very high, particularly Switzerland. And in Poland and Spain, much less. In Spain, less than 50%. They want the doctors to make the decision for them. So I was quite excited when I came back from my PhD in 2009, wanting to share this concept of shared decision making. So I presented it in the hospital conference and attended by quite a few people, and about we should do this shared decision making. And that's when I got a question. Actually, it's from Prof. Sanjeev, actually, who raised this question. Chirk, Jenn, this sounds all very nice, very Western, but does it work, actually? Our patients, most of the time, may want us to guide them in making the decision, or even want us to make the decision, which is still true, I think, in many ways. So I was really upset with Sanjeev because I said, what? How could you say that? But when I went back and reflect, I said, it's true. And this is, the previous slide just showed that, isn't it? So I asked myself, I said, this, hospital-based clinicians, they don't, but maybe he has a point there. So I actually went back and seriously think about it, and then I decided to do this study. And then Ranjini, who has now graduated, now the family physicians in Penang, did this study when she was a master's student in 2012, actually. Patient involvement in decision-making, a cross-section study in Malaysian primary care clinic. But bear in mind, this is primary care clinic, this is not in the ward, this is not in clinical kesihatan, okay? And this is what we found. More than 70%, okay, this is compared with Japan, but if you just look at Malaysia, 50 plus 20, about almost 3/4 want to be involved in decision-making. This is all the walk-in patients in Gluca, including those with chronic diseases. Only about 25% want the doctor to make decisions for them. So I got the answer, all right? And then we also found that the only thing that's associated with their preference is actually their household income. Means that those who are poorer tends to want the doctors to make decisions for them because they do not perhaps have much options. And this is the only place they can come to because it's cheaper, for example. And we also found that we asked the doctor to predict whether they can guess what the patient wants. Do they want a more autonomous role or something they want the doctors to predict whether they want the doctors to make decisions for them? We found that the doctors failed terribly when they asked them to try to predict whether the patients want to be involved or not. So which means that we are not very good, we meaning the doctors and the healthcare professionals, are not very good actually in understanding what patients want. So I think this really is also a wake-up call. But we just completed another study, but this time in a rural setting. Unfortunately, it's just we just analyzed the data, and it was done in Kuala Langat, somewhere near Banting, but in a rural setting. And we found actually the opposite, meaning that 75% of them want the doctor to make decisions for them. I need to be balanced. Otherwise, I'll be just telling you the positive findings, right? And then The other quarter actually did not want only a quarter wanted them to be involved in decisions making themselves. So there is variations. So, but we don't know who are the ones who want and who are the ones who don't want. So I think more needs to be done on this. And then we went on, a group of us who are really interested in shared decision making, came together and then did what we call a situational analysis, a scoping review, whereby we wanted to know what's happening in Malaysia. So we published this paper, an overview of patient involvement in healthcare decision making. We looked at the clinical practice, the teaching in undergrads and postgraduate. We looked at the research done in this area. We looked at the policies. We looked at the laws and legislations. Very little done. And very little in the curriculums is about decision-making, patient-centered care. It's all subsumed under communication skills, consultation skills. It's all in the hidden curriculum. It's not explicitly sort of tested as such. So there's a gap. There's a gap. There is actually a sort of a policy of sort that's already published by MMC saying that we must involve patients in decision making, and it's quite explicitly laid out. But that was already about 15, 20 years ago, and it's still not being implemented until now. So what's happening? And let's go back again. So with all this, with the gaps and all that, so how are we going to help Madam Tan in this consultation? Can we do something about it, or are we going to just live with it? And there are actually different ways of helping patients to make decisions. I'm sure some of us have made difficult decisions in our lives, not necessarily health, but in terms of health decisions, these are the three ways that people have actually done research on and found to have some evidence. First is patient decision aids, which I'll tell you more about it. Second is decision coaching, whereby the healthcare professionals or counselor teach people how to make decisions. Third is actually training the healthcare professionals in communication skills, consultation skills, so that they engage patients in decision making. Which one do you think is the most effective? I wish it's the third, but actually this is the one with the least evidence. Okay? And it's been found to be actually not so effective. Decision coaching, some evidence. The one with the most evidence is actually the patient decision aids, which actually is what I've been doing for the past, I would say, 7 to 8 years. I started with my PhD, didn't know what our patient decision aid all about. It's only through literature review I discovered that. And that was the early phase of this patient decision aids research. And then now I'm doing a bit more. And you may ask what patient decision aids are. It's basically an evidence-based tool. That means it's based on scientific evidence. And it tells patients about the risks and benefits of the treatment. For example, the risks and benefits of mastectomy versus lumpectomy, insulin versus no insulin. Questions to explore what's important to patients, something that we don't usually ask in or explore in education pamphlets, for example. It facilitates the doctors or the nurses in the consultations, but not replacing them. And it should not by right influence one person to choose one option over another, because most of the time as clinicians, we tend to influence the patients to choose one option over another. So if we are truly patient-centered, then we should actually leave it to them to sort of make their decisions without undue influence. And this is a clustered randomized controlled study that I've done in UK involving about 150 patients, about 33 practices in the general practices. And we've tried to find out whether a patient decision aids that's helping patients to make decisions about insulin, starting insulin, helps them to make a better decisions or improve their blood sugar level. And it's been found through this cluster randomized controlled trial that it improved patients' knowledge, how they perceive risks of getting a particular complications, they improve the involvement in decision making, and also reduces the conflict whether to make these decisions or that decisions. But there's no difference in terms of their blood sugar level, because some people may say if you let them make the decisions, then they won't start insulin, in which case their sugar level may actually go up. But actually we found there's no difference. And the consultation time, again, people may worry that by doing this, engaging, talking to them, you actually prolong the consultation time by using these decision aids, but actually there's no difference as well in terms of consultation time. So decision roles-wise, actually, how did you make your decisions about your diabetes treatment? As you can see, the treatment group, those with patient decision aids are more involved in decision making, whereas those who are in the control group, 21% of them still getting sort of decision made by the healthcare professionals. So there is an impact in terms of the decision role after using the decision aids with the p-values of less than 0.05. Same thing, for those who have made their decisions, how many of them actually persist with their decisions? We know that sometimes patients say, yes, I'll start insulin, but at the end, after 6 months, they stop using it because they got all the side effects, complications, because the decision is not an informed one. Again, you can see that those who are using patient decision aids actually persist. 68% of them persisted with their decisions, whereas 56% of those in the control persisted. Okay, that is a statistically significant difference between the two. But of course, decision aid is not the cure to everything. It's not the answer to everything. It has its limitations as well, as we have written in this the letter to BMJ. That, however, use of these aids is only one component of transformational change needed to promote and embed patient-centered care into usual clinical practice. We cannot replace a sort of patient-centered care with just using like decision aids and that's it. It requires the change of the health system, the change of the doctors, the nurses, the healthcare professionals' attitudes towards patients. These aids are not aimed at just saving treatment costs, but can also help change the relationship between clinicians and patients, particularly in the management of long-term conditions. The routine use of patient decision aids are part of whole system change, can also facilitate the introductions of other patient-centered care initiatives such as shared decision-making, support for self-management, and care planning. And this led me to the projects that I've been doing for the past 7 to 8 years. We call it the DIMIT project, or the Decision Making on Insulin Therapy, whereby we try to develop decision aids to support patients in decision making. As you can see, this is a website actually, and it's now DIMIT 3. It was 1, 2, and then now 3. So now this is at the implementation phase. At the first was development phase, the second was actually at the developing in the health innovations, and the third phase now is the implementation phase. And this decision aids was developed based on a specific framework. Whenever we do develop an intervention, I think it's very important to keep in mind that these interventions is not because we like it, is useful, but because it must be developed based on the needs of the stakeholders. So we actually interviewed patients, doctors, nurses, pharmacists, policymakers in the process of developing this decision aid. And something that I learned is that we must involve the patients in research, in telling us what is important, what is needed in research at the early phase. They don't come in as a participants of your research, but come in as the development of your research. And more and more we are doing that, and nowadays I think most of the projects would have a patient involved when we develop an intervention, and we find it very useful. We need to train them, and I think one of my patients, actually, I think Mr. Chong, my patient who has give us a lot of feedback about some of the interventions we have done, and we really thank him for that. And from this, we published quite a few papers, and I'm going to show you some of the lessons we have learned from this. And one of the key things that's different from the other decision aids developed in other countries, I'm going to summarize it for you, actually is the cultural difference. When we develop a decision aid, when we try to develop something that is import something from the Western world, I think we have to be very careful. We should not just import it and implement it. And this we learned also from this particular study. I'm going to share with you some of the things that we must consider when we develop an interventions, particularly for patient-centered interventions. Language barrier. I think you all know this very well. Language barriers were common, especially when healthcare professionals did not know the patient's preferred language. This particular Malay man in clinical kesihatan said, tapi bahasa English saya tak faham. Saya faham sikit-sikit, bahasa Melayu mungkin boleh faham. Fortunately, most of our patients, doctors and nurses can speak Malay, right? My Malay is not very good, so sometimes I struggled. But it's very important to speak the lingua. Same goes for dialect speaking, Mandarin speaking, or Tamil speaking patients. All this decision making is very difficult if you don't speak their language. A doctor said, a medical officer in clinical science said, language I feel is very important. Barrier you have to overcome. I managed to get lots of Indian staff to be in the clinic, so basically when we improve the communication, the patient can accept it better. So they already implemented it by getting more healthcare professionals of that particular ethnic groups. So for that, we actually developed the decision aids in 4 languages. So we struggled with Tamil, but we did it eventually. It's a struggle. And we also developed healthcare professional guides for them. The other issue is this paternalistic healthcare model that's very commonly practiced. There were concerns that patient decision aids was developed with a hidden agenda to persuade patients to start insulin. This is a tool. Whenever a doctor gives a patient a tool, the patients automatically will think that, oh, you want me to start insulin, you're giving this tool, you must be trying to persuade me to start something. But actually, it's not the case. For example, this university-based primary care doctor said, they find that this is a tool for us to persuade them to take insulin. I think she perceived it that way rather than for them to see which treatment is good or which is bad. And for this particular patients in UMMC, at the rate they're going, that means the doctors are going, they have so many patients, I overheard them saying, today alone, 250 patients. Actually, we are more likely to get 500 to 600. You know, all this take time is a good idea, but how are you going to see it through is another thing. And the doctor must be committed to want it, or do they feel like it is a waste of time? And this is exactly what we found, I think, when we interview doctors. They think it's a good idea, but can we implement it in a busy clinical setting? Well, for that, we have to train. Sorry, it's a bit dark, and that's me. And the training, we have workshops, we have a guidebook, and now we have an e-learning module that they can go online and learn. Because, as you know, workshops is not sustainable, and you want to disseminate wide, we can't be conducting workshops all the time. So I think we're thinking of ways to how to implement this, the teaching and training the trainers. Use of complementary and alternative medicine, all the herbs, or the jamu, or the Chinese medicine, keep coming up again and again. And we know some of us are also taking ourselves. This Malay taxi driver, after seeing Dr. X, I was feeling the tension, meaning that she has to start the insulin, right? I was approached by this salesperson just below the clinic, right? He gave me this 44 types of vitamin, like ice blended kind of thing. I don't know, I just drank it. And he's a taxi driver, and for 1 year, he has been drinking this every day. It's almost like TB patients coming back for their drugs or something like that, dots or something. And it's effective. You know why? He lost weight. By drinking this, the salesperson also said, if you drink this, you cannot take a lot of meat. You have to cut down your rice. You have to eat healthy. Only this juice will work. Of course it worked, because he lost 10 kilos. He was obese and now he's 10 kilos. So of course it worked. But he didn't continue on because it's expensive. And he has to drive there every day and do it. So, but this is what happens. Perhaps that might work. In fact, it's not the juice, as you know. It's the advice that goes with it, and which we have been telling the patients. It's the perceptions of the patients about the drugs we are giving them, I think. And I think it's only if you engage them, find out their concerns, their needs, then we can address this problem. Then our interventions will be effective. Then the sugar will be controlled. This private GP said, and when you tell them your diabetes has come to a stage where you need injections, they will say they have these herbs and so on. They want to try the herbs first. So for that, we put that options in. As you can imagine, the struggle I had when I tried to put this into the guide. We have a lot of resistance from the clinicians. They say, how can you put complementary and alternative medicine as an option for the patients to choose? We don't believe it. That's not evidence-based medicine. But that's an option for the patient. if you truly are thinking about patient, this is an option for the patient. So why can't we put this in and then discuss it at our normal consultation? If you don't put it in, patients will not tell you they're taking it. If you put it in, then patients say, oh, you actually realize this is an option. Then I will tell you that actually this is an option. Then we can have a discussions about it. Okay. The next one is family involvement. I think we know that Asian culture, family is very important. When I said that to my Western colleagues, I think they say, no, family members are also very important to us, but maybe to a different degree, as how much we're going to help sort of involved in the care for our family members. This is very interesting explorations of not just family involvement, but also patients' values. Look at the first level. Okay, these patients believe that insulin is expensive. Yeah, I feel I want to save money. My insulin is expensive. I don't want to take it. Just want to take one fluid, one tablet. Okay, this patient is a 55-year-old female. 66-year-old female. And when you probe a little bit more about their life goals and philosophies, I'm mostly thinking about work lah. My son-in-law, children, how much money can they give? My daughter has her own family. My son also has his own family. So his priority is his children, his family, not his health. And we look even at the broader circle about background. Patient had to support family after loss of husband's job. I suffer a lot one. Well, slang. My husband retired at 55 because the doctor asked him to stop working. That time, he has heart problem. That's why every cent I earned, give it to my son and daughter to study. That's why every cent is so important to her. And that's why he feels that it's very difficult for the children to earn money, so he doesn't want to disturb them. That's why he feels that insulin is expensive, though she can afford it, but he just doesn't want to spend the money. He doesn't want to ask for money from the children. So when we talk about this, if we want to discuss insulin with this lady, you cannot just tackle herself. You have to involve the family as well. Maybe talk to the children, find out more about it, get them to talk about it. Otherwise, we can't solve the problem. And for that, we put this into the decision aid, what's important to you, and then that my family may not agree with me starting insulin, or at least this is a thing that they talk about the family. So we want them to tell us about it. And the last point is insulin halal? This came out in our interview as well, whereby the purity of insulin injections was some of the concerns for the Muslim Hindus. This is particularly true in the rural setting, because we interviewed patients from the rural setting as well. There were also concerns about injections during the fasting month for Muslim. How can we inject ourselves during fasting month? Because that would mean that you're not fasting. If you cannot fast, you pay fine. That's his perceptions. I think they were thinking about insulin is from non-halal products. Okay. So these are some of the concerns we have when we develop a patient-centered tools. We have to take all this into considerations. And for that, we actually put in this checkbox there for them to tick whether insulin is halal or not. So that's just the insulin patient decision aids. That's just one of the options we can use to help us to implement shared decision making, putting patients in the center of care. There are other decision aids since then that have been developed. Julia is here, Prof. Julia. She has developed one fantastic tool on Bladder Explorer, which helps patients with spinal cord injury who are making decisions about the bladder drainage methods. Which one to use? Should they use indwelling catheter? Should they have operations, to have in situ catheter? Should they just go on diapers without having any catheters? These are the options. And these are those who struggled to use. So she has developed an iPad version of the decision aid to help them. And of course, Aisha is not here, Prof. Aisha. Together, we have sort of built this decision aid to help women with early breast cancer to make decisions about whether to choose mastectomy or lumpectomy plus radiotherapy. So what are the options available? And this has also been developed into a mobile phone app. And last but not least is prostate cancer decision aids, which I have the honor of developing it together with Prof. Lee Peng Yin from UPM and the team, and trying to develop. We have already developed this for patients with men with prostate cancer, helping them to make decisions. As you know, early prostate cancer, there are lots of options available. So all these are fine, but can it be implemented? Otherwise, it's just on the shelves of the researchers, okay? very nice to show, but not being used. How do we implement it? We are still in the process of trying to find ways to do that. And in fact, that's DMIT 3 is trying to do that. But one way of doing it is to actually update our decision aids. You saw the first versions. Actually, we ran out of it because we printed about 100,000 over. It's ran out, so we have to print the next one. And during the second versions, we update the information, change the layout based on the patient's feedback. And we also develop a website for those who have no access to the book. They can at least go to this interactive website and then to actually do this. Some of the patient's family actually wanted to look at decision aids. So if they didn't come with the patients, if they don't have decision aids, at least they can go to the websites and find out. And there's also an iPad applications they can use if they want to. And we also developed an online healthcare professional training modules, which was parked under UMMC website, but I think now there's some restructuring, so I think we need to put it back again to guide the healthcare professionals on how to start to use the patient decision aids. We also have a booklet form. All these are available freely online at the website. Yeah. So with that, actually, then we actually try to use it. And at the moment in the Ruka clinic, in a few of the clinical settings, people are using it. And now we're trying to do a study to find out whether it's sustainable, what kind of strategies work best to how to implement it so that people will use it. Not just short-term during the research period, but long-term and incorporate it into the routine care. So that's the story about the decision aids and shared decision making, and one of the many ways to put patients in the center of our care. Next, for the next 10 minutes or so, I would just like to share a little bit of my other interest, which is on men's health. Okay, some of you might know me as more like a men's health person rather than shared decision-making person, because recently we've conducted the Moustache for Men campaign in UMMC with a strong support from the UMMC management. So this is the Men's Health Initiative, Moustache. I actually grew moustache for a month, actually. But somebody said they didn't notice the difference, actually. So well, I'll try again this year. So we had this poster exhibitions and all that. The reason why I bring this up, what does it have to do with patient-centered care, really? Or because I feel that the next level, besides at the clinical level, is actually reaching out to the community, to people out in the community who maybe do not even come to the hospital or the clinic. And if we really put people in the center of care, then we should reach out to them. We should go to where they are. And this is where I find I have the opportunity to work with Sylvia and Adnin in a project in Hospice Malaysia, whereby their patients are most of them out in the community. It's when you go there and visit them, then you realize the issues that they have. Then we truly can occupy that blank space of 364 days and 23 hours. Because that's where they're living. Even then, we only see a snapshot view of that. My involvement with the Tzu Chi Foundations also helped me to do some home visits, to see people out in the community, which also guide me to think that, yes, truly, if you really want to understand them, the best way is to just go to them. And this is what we did. These are posters well designed by Chin Hai and the team, and take a moustache and pass it on. So things like that. And during that campaign, we screened about 200 over people, men, and we screened and then found that many of them actually have depression that has never been diagnosed. And we used the score to sort of assess it, and we found that many of them are severe depression. And they could not just hold back and just tell us about their problems. And we are so glad. I mean, those people who are there, the doctors who are there, I think they find very grateful because they find that they really make a difference, because these are people who are on the verge of really collapse in terms of their mental health. So I think it's something I find that is something we should do more, the campaign, and open up to people and telling them where to seek help. And this is a photo. I was trying to look for photos for my other projects. I found that I had very few photos. But this is one of the things. Why I put this up is because I think the next thing we should move to sort of push patient-centered care to the next level, in this case men's health, is that we need to involve different stakeholders. In this case, we have Dr. Kamalia, who is from the Ministry of Health. She's the Deputy Pengarah of the Family Health Division, who I met yesterday because we are now going on to try to develop a policy for men's health. And we have external speakers or professors in men's health from Leeds, Prof. Ellen White. And of course, we have Dato, who is a champion of men's health in Malaysia, who is from NGOs, from the private sector. We have Prof. Tay, who is an demographer. We have Prof. Shaifu from USM, Prof. Ong from of course, Sharina, my boss, Tong from UKM, and Zakia from MOH, and Prof. Ng from SPM, Health Economist. Why I'm showing you this is because I think for things to work, you need a whole team, and you need to involve many people from different disciplines, different institutions, and what's missing here is actually a patient, okay? But we have many men here, and at some stage of our lives, we are all patients, okay? And of course, Chin Hai is the PhD student who is working on this project. So it's through this, we have different stakeholders that we come together and try to champion a particular cause, in this case, men's health. And of course, there's a website, some advertisements there. We also produce the Asian Men's Health Report, which is now widely circulated. It's the first in Asia, and I have the honor of doing it together with Prof. Tan, as well as Chris Ho from UKM and Chin Hai as well. And we went on to publish this, which have received a lot of feedback about status of men's health in Asia. And we also did a Delphi survey where we surveyed the key stakeholders across the world about their views about how we should move men's health forward. So currently, we're trying to develop a men's health index, which is trying to measure the men's health status in each country so that policymakers then can assess the men's health status in each country and compare with another country so that they can gauge where they are. And it's through this that policy perhaps can be shaped and changed, and men's health in this case can be improved over time. So this last bit of my lecture actually is more about trying to move things perhaps at a higher level. Perhaps in the next 10 years of my life, I will try to move a little bit more in shared decision making and try to push this across. But I know Ministry of Health is already thinking about that, and patient-centered care, shared decision making. So I hope I could join in and provide more evidence and do more interventions to try to put patients back in the heart of care. And this, back to Madam Tan again, I think no matter whether you are medical students, whether you are a nurse, a pharmacist, a doctor, a professor, a hospital administrator, a policy maker, I think we need to really listen to Madam Tan and what she has to say. What her needs are, response to her needs, address her concerns, knows about her life, knows about the 364 days and 3 hours that she lives with besides health. Only then can we put patients back to the heart of care. With that, I thank you.
Distinguished guests, I would like to call upon Professor Dr. Adiba Kamruzaman to conclude the lecture, which has been delivered by Professor Dr. Jenn a moment ago.
Thank you, Chirk Jenn. You didn't disappoint us. Taking the first inaugural lecture for 2016, and I think everyone in the audience, I'm sure, would agree with me that you've made us proud in the sense that you're the consummate doctor, consummate researcher, and also, that you, it came through very clearly that whatever you do, that the patient is at the center of your concern, and that you have beautifully married your academic prowess to answer the very, very many barriers and questions that that we all face. But instead of just throwing up your hands, as I do when I do ward rounds and I see someone's sugar is not optimum, but you have really beautifully, systematically tried to understand what goes on at the bottom of this. But not only have you done it in a research oriented manner in trying to understand the complexities, particularly of our patients here in Malaysia, where religion and family and everything else comes into play. And you didn't stop there, but you've also utilized your research and analytical background to then try and solve these problems through your through the decision patient, what is it called? The aids, the patient aids, and finally, in terms of your contribution to men's health, as you said, you're taking it to the next level. It is not just, for most people, you would think primary care physicians concerned about that one-on-one patient interaction that you all are very good at, but you've now taken it to the next level in terms of the preventative and the public health aspects of healthcare. And with that, I think it only leaves me to congratulate you, and we're very pleased that you decided to return to Malaysia and made such a huge contribution. Now your next task is to try and convince those who are still in Singapore to come back and show that we can be as good as them, and we can contribute to not just Malaysian healthcare, but to regional and global healthcare as well. So congratulations and thank you.
Thank you. Thank you very much, Professor Adiba, for chairing this lecture. I would like to take this opportunity to thank the management of the Faculty of Medicine, International Corporate Relations Office, citizens of University of Malaya, as well as all the guests who came here for your time. With this, we have reached the end of the lecture. On behalf of the University of Malaya, I would like to apologize if there has been any weaknesses from our side in organizing this lecture. Also, as a token of appreciation, I would like to invite Professor Dr. Nick Sharina Hanafi, which is the head of department for primary care medicine, to give Professor Ng a bouquet of flower as a token of appreciation and a congratulation note. I would also like to invite Ms. Ranita, who represent Professor Ng's students, to also give him another bouquet of flowers as a token of appreciation. Thank you very much, everyone. May I invite you all to a light refreshments that will be served just above this auditorium at level 4. And we would greatly like to see you there. Ladies and gentlemen, once again, thank you and have a pleasant evening. Thank you very much.